I would now like to introduce your moderator for today, Dr. John White, Director of AHRQ Health IT Portfolio. Dr. White, you now have the floor.
Well, thank you so much. I appreciate the introduction. Welcome, everybody. Delighted to have you join us on a Thursday afternoon, at least on the East Coast. Very pleased to be able to bring you a great panel today, and we'll discuss the panel in a second and what we're going to be talking about. Those of you who know the agency may not need this introduction, but just in case there are some of you on the phone who don't know the Agency for Healthcare Research and Quality is an operating division of the Department of Health and Human Services focused on improving the quality of healthcare for all Americans. A long-standing subject of interest in the agency is the topic of health information technology and how you use it to improve healthcare. And I'm proud to be the leader of the group at the agency that focuses on that work. It's been quite a ride over the past decade, which is almost how long I've been here. And we've got some great things that have come out of the agency that have contributed to the national initiatives of which you're all likely aware around health IT and quality improvement. So getting down to the topic today, we're looking at how do we've had this surge in adoption over the past 4 or 5 years, fueled by the Recovery Act and high tech. We're working hard on getting towards stage 2 now, which of course is, as ONC says, is all about health information exchange. And then beyond that, on the very near horizon, is going to be stage 3, which is about improving outcomes. And this is where a lot of our work is focused. So we're very excited for this stage to come upon us. You all joining us on the webinar today are amongst the forward thinkers, realizing that this is where we're going and wanting to learn about it. And you have experts here who have done very substantive work. I think that as you go through the presentations that you're going to hear, you're going to find a lot of detail. Those of you who are saying, well, how do I do that? And where do we begin? I think you're going to hear stuff that will satisfy and intrigue you today. You've got some real experts with you on the line. I'll introduce them one by one. I do need to offer you our disclosures for moderator and presenters. There are no financial, personal, or professional conflicts of interest to disclose for the speakers or for myself. So with that, let us move to our first presenter, who is Lynn Nemeth. Lynn Nemeth, Ph.D. and R.N., is an associate professor of nursing at the Medical University of South Carolina in Charleston, South Carolina. Dr. Nemeth divides her time teaching between teaching and research. Her specific research interests focus on quality improvement and patient safety in primary care, promoting preventive services and a patient-centered approach, practice development using electronic health records, and process evaluation. Lynn has been a co-investigator, project director, and principal investigator within 10 studies over the past decade funded primarily by AHRQ and NIH within PECARN, which is a practice-based research network with 179 active practices in 39 U.S. states. Lynn has done a lot of fantastic work for us, and now I'm going to let her tell you about our stuff. Take it away, Lynn.
Which is actually coming from the Synthesizing Lessons Learned project using Health IT. This particular project was designed to identify the strategies, barriers, and facilitators of successful quality improvement efforts by practices that are using the same electronic health record, which is the McKesson Practice Partner, EHR. In this study, I synthesized lessons learned in 7 distinct studies that translated research into practice. The studies all were quite different, so it provided an opportunity for us to really explore how our network practices really made change happen. Tell you a little bit about PPRNet. PPRNet is a practice-based research network that's consisting primarily of practices that are primary care practices. They're usually small, community-based primary care practices. Some of them are larger. They are urban and rural, all over the United States. Our aim is to answer community-based healthcare questions and engage in quality improvement activities with our practices and transcend individual projects so that we have an ongoing network that people in these practices can be affiliated with for their development and continual learning and improvement. So we are indeed a learning organization. As I said, we consist of small to medium-sized primary care practices in 39 states. We've had as many as 224 practices as members, but there's variation in those numbers due to different arrangements and purchasing of systems, numbers, and changes in EHRs. We see some change in the numbers, so they do vary. But overall, it's great that we have a wide national presence, and you can see on our map that we are located in many of the states, the majority of the states. Our aim is to turn clinical data into actionable information. We receive practice-based extracts from practices' EHR data, and then we work with the practices to test theoretically sound interventions to improve healthcare quality. We're disseminating successful interventions, and for the practice, we are doing quality improvement, and for the funder, we're doing research. So practices really like the idea that they are improving, and that's what is the hook for them, and we know that we're contributing to the research data on how this improvement occurs. So again, as I mentioned, the background to the study is that we've been doing a diverse set of primary care studies, and all of the findings and focus of these studies were very project-specific. After a while, we wanted to know what is the learning about these studies, about overall how practices make improvement while using their health information technology. And more importantly, as we develop towards high-performing primary care teams that are rewarded for their quality, we wanted to know what is needed to develop these teams. Well, here's the background on the 7 studies that were in this particular study, this RO3 that I led. Our first study was TRIP2. It focused on heart and stroke secondary prevention. It was funded by AHRQ in 2001, and it ran for 2 years. We then expanded in the next study to accelerating translation of research into practice, where we got involved with we got 100 practices in our network to participate, and we expanded the set of indicators that were generally relevant to primary care practice. Around the same time, we had a collaborator who wanted to study alcohol screening and brief intervention, and he found PPRNet to be a good place to take that message into primary care. So we collaborated with Dr. Peter Miller to do our first alcohol study, which was an R25 funded by NIAAA. We then got involved in colorectal cancer screening through NCI, medication safety study through AHRQ, which was very interested in looking at medication safety issues and patient safety issues in their portfolio. We became involved in a task order from the Practice-Based Research Network Master Contract to do a standing order project from 2008 to 2010, and that focused on screening, immunizations, and diabetes. And lastly, we just concluded our second alcohol study, which focused on adding medications to the expert intervention through NIAAA. Well, we started with a model for how to activate practices. And this model grew out of grounded theory studies in our first TRIP2 study. The model had 5 elements, which involved prioritizing performance as a practice, making sure that practices kind of set a goal to do better, involving all staff, which is self-evident, making sure that all of the staff were on the same page about what they were prioritizing performance on, and then taking steps to redesign the delivery system. Of course, activating the patient and using EMR tools was the key thing that was going to help them focus their efforts. Additionally, we also developed a practice development model, and this took a little bit deeper look, actually was my dissertation study which was concluded in 2005 but published in Implementation Science in 2008. It involved having a vision with clear goals, involving the team, enhancing communication systems, developing staff knowledge, really so that they could understand the rationale behind what they were doing, and taking small steps, all with the core vision of assimilating the electronic record to maximize their clinical effectiveness, and then using feedback from performance reports that were provided from PPRNet from their practice extracts to be able to reset the vision and priorities for improvement. We found that this was very helpful for practices to set practice goals for improvement and actually get improvement happening in the practices in PPRNet. So the methods for this synthesis study was to do a secondary analysis of mixed methods data from the 7 studies. We took field notes and observations at practice site visits during all of those studies. We also conducted network meetings, which were like annual CE learning events, where practices came in and learned from each other, learned best practices, and got ideas about what they might be able to do in their own practice. Memos that we took during those events, correspondence that we had with practices, and then specific interviews. All of this data was merged within an in vivo database, and I particularly, as the PI on this project, immersed and crystallized the data and created a cross-case comparative analysis matrix. It was basically taking the key features that were found across all of the studies, because that's what we're looking for. What are the lessons that cross all of the studies, regardless of the specific focus? We then conducted member checking by the practice members to make sure that we were right with what we were coming up with, and to revise that as needed. Well, the findings of this were that we had 134 practices engaged in research with PPRNet during those 7 studies, and we formed a collaborative learning community in those practices. We also, most notably, found that practices used their health information technology and staff in new ways during the course of those 7 studies, or in that decade. And that these were really complex interventions that were being implemented, and it relied on 4 main concepts, which are very similar to the initial 2 models that I showed you, but maybe more parsimonious. And these were developing a team care practice, adapting and using HIT tools, transforming practice culture and quality, and activating patients. Let's take a look at the model. I tend to be a very visual person, and actually I've found that going to practices and presenting them with a vision helps them generate some action on this. And so taking a look at the model, activating patients is in the center of the circle here, and it's all about transformation of practice culture and quality, developing a team care practice, but of course adapting and using HIT tools that this whole business is all about. In order to do this, you need investments in HIT resources. Practices need to set aside the money, the financial resources to buy the system that works best for them. They need to set aside the resources to educate and develop their practice team and make sure that everybody knows how to use that. And they also need to establish leadership in the practice so that there is a go-to person in the practice who can help resolve issues regarding all of these concepts of team, tools, transformation, and patient activation. We found that improved outcomes is the focus of this, and so our practices were actually making improvements on their PPRNet report data, which there are numerous measures in our reports. NCQA measures, patient-centered medical home criteria, CMS, and meaningful use attestation were starting to happen. So improved outcomes that were relevant to the practices were being seen. Rewards, well, when practices started to actually see financial alignment with their quality measures, they also were able to retain staff and providers. There was a better fit with everyone in their role and how this worked together. Now, of course, that's not to say that there is not variation in this, but overall, these were some of the lessons, the key lessons learned. To give you an example of what the specific strategies that were seen across these different studies, this matrix here shows how practices actually kind of evolved along the way. The involve all staff, for example, started in the early 2000s as new roles and responsibilities, clinicians agreeing to decrease practice variation. And that moved on to the next phase of it, where structured screening tools were used by medical assistants and nurses, and that there were teams closing the loop. After this process of better defining the roles, providers could close the loop on what was needed. And that from 2007 onwards, we started to see things like medication reconciliation and outreach as needed, that teams were actually starting to do things that they didn't do before. In terms of adapting and using HIT tools, there was general agreement that staff increased their use of the EHR from using a very small bit of it to using much more of it in the early stages, and then moving forward to starting to use specific templates for decision support, revising and editing their utilities within the record, adding macros, applying age, gender, diagnosis, and medication-related templates, and of course lab interfaces, scanning, and e-prescribing. We saw in the medication safety study that we were doing much more use of these templates being applied, medication and diagnosis templates that would stimulate appropriate consideration of medications prescribed and dosing alerts. Transforming practice culture and quality focused on things like emphasizing goals, celebrating successes, having quality coordinators, to having liaisons actually lead projects within the group, staff education and standing orders, and explicit practice culture that's rewarded by pay-for-performance rewards. And again, seeing that performance reports were starting to be used for things like outreach, refill protocols, printed medication lists, etc. For activating patients, they started out using handouts and posters, having events, press releases about what's going on in the practice, to having very targeted messages that focused on the kinds of studies that we were working on at the time, like the alcohol messages and the colorectal cancer screening and the follow-up for completion of tests for diabetics, etc. We started to see the use of patient update forms where patients were asked to bring in all their meds, have a medication reconciliation, go through the standing order kind of health maintenance procedures that they might be due for, and having things like long appointments for medication reviews. So what were some of the barriers we found along the way? Well, some included having lack of practice leadership, not having a leader or someone who was willing to take leadership on setting goal vision in the practice, not having agreement by providers on that this is the approach we should be going towards as a practice, and we're going to, the idea of just we're providers and we do it all our own way. Some other barriers included not having the technical support and expertise to use their tools as they should. Of course, turnover from staff and provider perspectives, organizational change and practice ownership were issues that set practices up for trouble with having continuity and making progress, and the differences in which individuals use HIT to facilitate the workflow in their practice. However, equally, we found that there were very clear facilitators. Practices had policies and protocols. They started to do more with their staff education and have leaders in the practice follow up. Communication systems started to become more improved. The tools and templates that staff were now using were improving workflow and efficiency. And this kind of practice-wide approach reinforced the staff adoption of extra responsibility and expanded roles. And having providers close the loop on what staff initiated actually helped patients to adopt what was being recommended because they were hearing it early and hearing it often, a repeated message. So in conclusion, practices expanded their use of the EHR. They added many enhanced features to support quality improvement. They actually recognized the value and asset of their staff in being able to support quality improvement goals, and they often shared those rewards from pay-for-performance bonuses with their staff. These kind of recognition and rewards have been very powerful motivators to the practices that have done well, and in fact, patients are very receptive to the expanded roles of the practice team. So, with that, I will acknowledge my funder, AHRQ, for supporting this RO3, the PPRNet practice providers and staff, of course, the research team in PPRNet, which has a long history of collaboration, and the consultation that I had from Brian Mittman, Lisa Rubenstein, and Elizabeth Yano from the VA system on implementation science, coaching, and understanding some of the mechanisms behind all of this. With that, I close. Thank you.
All right. Thank you so much, Lynn. Wonderful presentation, a good description of what it's like to be boots on the ground with this stuff with actual evidence behind it. So thank you so much. I do want to briefly mention two aspects of the presentation. The first is that if you look at the bottom of your screen, if you're following along online, there is an area for questions and answers. So if you do have questions, feel free to submit them down there at the bottom. If there's time between presentations, and there are clarifying questions for the specific presenter, I'll try to ask them between presentations. But otherwise, for some of the more general questions, we'll ask them of folks at the end once we're through with all three. The other question that had been raised up till now that I wanted to address is, will these slides be made available? Thank you. I think that means that you find value in these the slides that you're being presented. All the materials for this, I think including an actual recording of the teleconference, will be available within 2 weeks on the AHRQ Health IT event site, which is healthit.ahrq.gov/events, EVENTS. So that is where you will find materials, and it takes a little while to make sure that everything is nice and cleaned up and compliant with all the the standards that we've got to follow. So that's why it takes 2 weeks. So thank you so much. Let us move on to the excellent Dr. Parsons' presentation on improving the quality of care in EHR-enabled practices. Dr. Parsons, MBA, MD, is the Deputy Commissioner of the Healthcare Access and Improvement at the New York City Department of Health and Mental Hygiene. Here at AHRQ, we like to call her Farzad 2.0 because that's who preceded her in her job. She oversees the Primary Care Information Project, Correctional Health Services, Primary Care Access, and Planning Bureaus for the agency. Prior to that, Dr. Parsons served as PCIP's Assistant Commissioner after serving as the Director of Medical Quality, where she was responsible for creating and leading the Quality Improvement Billing Consulting and EMR Consulting teams deployed to PCIP's small physician practices. Prior to joining the Department of Health, Dr. Parsons worked for McKinsey & Company as an engagement manager, serving clients in the pharmaceutical and medical products and global public health sectors. She earned her MD and MBA from Columbia University and completed medical postgraduate training at Beth Israel Medical Center in internal medicine. Dr. Parsons is a frequent presenter and panelist focusing on quality improvement, electronic medical record adoption, patient-centered medical home, and meaningful use. With that, Dr. Parsons, please take it away.
Thank you so much, Dr. White. So it's a pleasure to be invited to speak with you today. I hope that my presentation will cover some of the learnings that we have elucidated from the many years of working with small practices, community health centers, and other settings in New York City. So I'll first give you a brief overview of our program just to lay the context, and then I'll go right into the lessons learned. So for those of you who aren't familiar with the Primary Care Information Project, this was a mayoral initiative funded by Mayor Bloomberg back in 2005. It was the mission of the health department, obviously, to promote health and to prevent disease. And our specific bureau's mission was to do that leveraging health information technology, which, if you can imagine, back in 2005 was sort of a relatively new approach for a health department to think about how to improve the population's health. And so we are often viewed as the clinical action arm of the New York City Department of Health. And what we really do is we work with practices, we help them get data, turn that into information, turn that into action, and then disseminate the findings. So far, we've also been selected as the New York City Regional Extension Center. So in addition to working with the 3,000 providers for whom we procured and helped implement electronic medical records, we're working with an additional 6,000 providers who have procured their own EHRs and whom we've assisted through our Regional Extension Center grant. And so that gives us a pretty large footprint. If for just contextually, there are about 30,000 providers in New York City. And we've been working with a variety of settings, a lot of small practices. So we have about 1,000 small practices, and those are real. When we say small, we're not joking. It's really 1 to 2 physicians make up about 75% of those small practices. We have 31 large practices, 63 community health centers, and then working with 54 hospital outpatient clinics. In terms of the kinds of services that we provided, so for the practices that we helped implement, again, that's the 3,000 providers that we got an RFP, we selected eClinicalWorks, and we worked with those practices to help them get live. We did a huge amount of work with those practices, everything from doing outreach and education and getting them to consider implementing an EHR back in 2005 and 2006, 2007, before meaningful use in any of the large movements were underway. We helped them with selecting the product. We helped them get group discounts on things like IT vendors and other on hardware and other barriers that proved to be at least insurmountable obstacles until we helped the practice tackle them. We also learned that we had to get practices ready to implement, and so we did a lot of readiness assessments and working with them to even help them find financing to afford the hardware because we were not at the time subsidizing the hardware. During the time of the implementation, we really worked alongside with the practices, helped make sure that the vendor was doing what they were supposed to be doing. We helped overlay some project management. Many of the practices, they would forget to return something that the vendor needed, or they weren't really good at sticking to deadlines and timelines, and so we overlaid a huge amount of work, or a huge amount of process around that. We, for the large practices, we helped them do some pre-implementation workflow redesign. For the small practices, we just did that after the implementation, but for the large practices, it was not possible to go live without thinking through that ahead of time, so we did that with the large practices. We connected doctors to each other to convince them that they weren't the only ones going through this, the pain and angst of implementation. And then we also got them CME credits for undergoing EHR training. Then they go live, and post-go live, we worked with them a lot. The first thing we did was help stabilize the practices, offering them revenue cycle optimization so that they could make sure that their billing hadn't either been disrupted or now that they were getting data on their billing, a lot of them were shocked at what they found and were really unable to engage in QI until we actually helped them understand how to bill properly. And so that became a pay-to-play to work with the practices. They really wanted to make sure their financial base was stable, and then they would engage with us on quality improvement. And I'll talk more about what that quality improvement and EHR consulting look like, but we did a lot of work with them around patient-centered medical home, and pretty much anything that they would engage with us on, we were really interested in working with them, all with an eye towards improving quality. And then over time, as the practices got to be more sophisticated, we were able to, and I say sophisticated not in a pejorative sense, but I mean in terms of the use of their electronic health record, we were able to layer on additional programs like our Pay for Performance program, which I'll talk about today, and some other patient engagement programs, and working with them on quality measurement, and as of late, we're working with them on interoperability. So in terms of I'm going to talk about a lot of disease areas that we focus on, but the reason we focus on those is because for New York City, the heart disease, lung cancer, pneumonia, diabetes are really the leading causes of death and can be largely attributed to and prevented by the proper use of aspirin in people who need it, proper blood pressure control, proper cholesterol control, proper blood sugar control, smoking reduction, and addressing obesity. And so, as you see in the slides that follow, that's really why we're focusing on these disease areas as opposed to others that might be also pertinent, but not from our public health standpoint, not as important as these leading causes of death. So in terms of what we have seen so far, so do we see improvements in the quality of care with providers who use EHRs? Absolutely. This slide here shows the improvements over time in practices that had gotten the electronic medical record and that we had been working with. This data shows trends from October 2009 through October 2011. We included here only the practices that were able to successfully transmit data to us. I should note that the practices, they have their own installations of the electronic medical record, but we built in a process whereby their electronic medical records spit out to us. That's a very technical term, by the way. They basically send us daily syndromic surveillance data and monthly quality improvement data. I have to be honest that this doesn't always work for every single practice every single month, and therefore, when we do these kinds of analysis, we have to limit them to the practices who have been steadily sending us data. And so this is a subset of practices. I think it covers about 600 providers over this 2-year time horizon who were sending us monthly quality measure scores. And we were able to take a look at, so the dark black line is the antithrombic therapy. So this is, again, the use of aspirin in those patients who have suffered ischemic vascular disease. The gray line below that is blood pressure control in people with hypertension, and you can see that's gone from 55% to 64% in 2 years. Hemoglobin A1C testing has gone from 46% to 57%, and smoking cessation intervention gone from almost 30% to 46%. And so we're really excited to see these trends. For those of you who've been following quality improvement trends, overall the nation as a whole is doing a little bit better, but certainly the rates of improvement are nowhere near what we're seeing here in the PCIP program. So do EHRs alone improve the quality of care? No. What we're finding is that we have to do the quality improvement work. It's not sufficient, and I'm sure that this comes as a shock to no one, but it's not sufficient just to enable the practices, even with electronic medical records that have a lot of prevention-oriented functionality. We really do have to send folks. Our boots-on-the-ground team have been the key to making these improvements. So since 2009, we've been maintaining a team of quality improvement specialists. Their job is to educate and facilitate the quality improvement efforts in areas that we choose to focus on, but often we find ourselves aligning what we would like to do with what the practice wants to do and finding some happy middle ground. We work with them on, like I said, these disease areas. We use the disease areas as a way to demonstrate to them the functionality that's available in their electronic medical records. So, for instance, we working them through even a blood pressure protocol. You would say, okay, are you, first of all, are you comfortable with the targets of, that everybody with hypertension should have a blood pressure control score of 140/90 or less? Or less than 140/90 for people with hypertension and less than 130/80 for people with diabetes. And we get them aligned on the goals, and then we work with them on, okay, how do you screen, how do you document, how do I identify people who have elevated blood pressures but don't have a commensurate diagnosis of hypertension? How do you call those people back in for care? How do you run a registry of patients who had elevated blood pressure, who had also a diagnosis of hypertension and who don't have an appointment in the next 3 months and haven't had one in the last 6 months. So those are the kinds of things that we walk them through as a way to demonstrate how their EHR can actually help address the particular disease area that we're looking at. And then we also work a lot with talking to them about the quality measures. Importantly, the EHRs can calculate the quality measures. They get some quality measure reports from us, and we work with them on understanding what those mean, how to think about them, and how to help improve those scores. And so we have been able to show on the next slide, and this is a study that was published in Health Affairs this year, basically that for practices who got 0 technical assistance visits, we used an aggregate sort of HEDIS quality measure score that was designed by Larry Casolino. and basically people who had no technical assistance visits from us improved very, very slowly, and actually they only improved after a long time of being on the EHR. People who got 3 technical assistance visits saw some moderate improvement again, but not at a particular high rate. And then those people who got 8 technical assistance visits really got a lot more bang for the buck in terms of quality improvement. So I think we understand the difficulty in sending out quality improvement specialists to each and every practice in the U.S. It's definitely not a very scalable intervention, but it's definitely one that works well. In terms of our pay for performance, does that work to improve the quality of care? What we found is yes, for many providers actually. Just briefly by way of background, we were able to get private funding from the Robin Hood Foundation to pay doctors to do the right thing for the ABCs. So again, the aspirin prophylaxis, blood pressure control, cholesterol screening, and smoking cessation intervention. And what we did was we paid, so doctors were randomized to either get no incentives or incentives, and then within the incentives, what they got was the first year they got $20 for doing the right thing for the patient. So if they got the blood pressure under control, they would get $20. We would double it to $40 if it was a patient with Medicaid or who wasn't insured, and we would double it again if it was a patient who had comorbid diseases. The idea was to pay more to treat the harder to treat patients. And what we found was that in the first year, all the practices that participated in control and incentive had some improvement in the ABS measures. For some reason, cholesterol did not show a difference in the first year. But those who received monetary incentives had higher increases and better performance. However, what was interesting is where we tried to double down for patients who had Medicaid or patients who had comorbid diseases, that doubling down didn't actually work. We're not quite sure why yet, but we were not able to, we did not exacerbate any disparities, but we were not able to directly address disparities by paying more for harder to treat patients. In terms of looking at the data for this, and we're actually working on publishing this data now, but where you see the A's, the B's, the C's, and the S's, again, I've noted below what those stand for. But you can see for the control arm, for instance, in aspirin prophylaxis, their score was 54% at the beginning of the program, and they improved to 60%. But those who were in the incentive group went from 52% all the way up to 65%. And you can see that in all of the ABCs, essentially the increase in the incentive group is much higher than the incentive in the control group. So we do believe that incentives can work to improve the quality of care. We also ran a similar program called Healthy Quits. Here, we didn't randomize the practices. Everybody was eligible to receive an incentive. The idea, though, we didn't pay for each time the provider did the right thing. What we said is we looked at their baseline and said for every patient that you get above your baseline score, so if you were 50% smoking cessation intervention to begin with, we wouldn't pay you on anything of the 0 to 50%, but if you got to 51%, 52%, et cetera, anything above your baseline we would pay for. Here we enrolled just community health centers, and over 19 of these practices participated. So the first thing that got better for sure was the documentation, even just of the smoking status itself, and then the cessation intervention rates increased from 28% to about 52%, both looking at the average increase for practices as well as the practices who were doing well in the 90th percentile. You could also see that increased as well. And then when you look at the practices, I apologize for the quirky nature of this slide, but the numbers at the bottom, 15, 3, 4, 18, et cetera, that's the blinded number of the practices. So you could think of this graph as each bar is a particular large practice. We've de-identified it. And you'll note that there in the blue was their initial rate of smoking cessation intervention. So for instance, practice 15 was doing abysmally because they did not have any smoking cessation intervention that was detectable. Some of that for this practice was indeed documentation, but they just weren't making good use of the fields, nor was their leadership focused on this. by the end of the practice, they had improved somewhat to 16%, which is still low, but we were excited to see some improvement. And then you can see for some practices, like practice number 16 and practice number 13, these practices were overall doing, relatively well to begin with. About 50% of their patients were getting smoking cessation intervention, and they increased up to the 58% and 65% commensurately. And you can see from this practice, not everybody did better, but some people did much better. Like practices 19 and 12 really went from doing it 6% of the time to going up to 69% of the time. And what we found in this was really it was important for the practice leadership to be bought into the process and to really drive it home. And then to implement, I think as the previous speaker had mentioned, it was the practices that implemented policies and procedures and reinforced it through messaging really did a lot better. Other practices just sort of didn't really want to engage at the leadership level, didn't really talk about it within the community health center. And so you can see for those practices, not much, some improvement happened, but not much. We've also looked at whether or not patient-centered medical home certification means a higher quality of care, and what we're excited to report is, yes, we do see that patient-centered medical home practices seem to provide better quality of care in terms of clinical preventive services, which is what we studied, but of note, they actually started out higher. And so what we did to look at this study was over 2 years, and we looked at practices who were patient-centered medical home and those who were not patient-centered medical home. We looked at 7 measures, and initially on all practices, like I said, had practices that were patient-centered medical home had higher performance, and they continued to have higher performance on the quality measures. And interestingly, we make our quality improvement visits available to everybody. We try to reach all of our practices, but certainly if a practice requests for us to come, we're more likely to go than for a practice who doesn't want to engage with us. And so of note, the patient-centered medical home practices also requested more quality improvement visits. And when you look at the scores, and I apologize, we're still in the process of submitting this for publication and still working on the graphs, so they're not very beautiful, but the blue line here is practices that reached patient-centered medical home certification, and then the line in red represents practices that did not get patient-centered medical home certification. And what you can see on antithrombic therapy on the top left, and BMI, blood pressure control, and hypertensive blood pressure control in patients with hypertension and diabetes, smoking status, and smoking status intervention is you can see that at baseline, for the most part, on almost every single measure, the patient-centered medical home practices start off higher, and their rate of improvement, they improve. The patient-centered the non-patient-centered medical home practices also saw some improvement. But and that's because also for all these practices, but whether they're in the PCMH arm or not, we're still doing quality improvement. We've still been doing our other interventions, so it was hard for us to strip out just PCMH as a factor alone. But we do see better care in patient-centered medical home practices relative to those who are not. And we understand that there's a self-selection bias and other biases that are at play here, but that's what we've learned so far. We've also been looking at how do providers respond to performance feedback. So in having the quality improvement specialists go out to the practice, they've been able to give verbal feedback, but we wanted a more scalable model to interact with providers, and so we created what are called dashboards, where we take the data that they give us. I think I mentioned before, these practices submit to us monthly quality measures, and as long as we get data that's complete for the practice, we then turn it into a report and we give it back to them on a monthly basis. And we have gotten great response from that, and I think we've learned a lot. Practices have told us, we really like to hear from you. We really like to hear from you. We feel like you're not scolding us. We feel like you're working with us, and that's been really important. So I put in here, it's important to be not judgmental and to make the practice feel like you're really on their team, you're their coach. This is an example of one of the dashboards. It's very busy, and I won't spend a lot of time unless somebody has a question explaining it. But essentially, these are spark lines. They're 6-month trend lines. We note the practice performance. The straight line shows the benchmark of the average of the PCIP practices. So, for instance, if we look at this A1C testing for this particular practice, their 6-month trend is variable, but then has recently plunged to 46%, and that puts them below the average PCIB practices, which is at 50% do A1C testing. And actually, we were able to, when we saw this for this particular provider, we called them and said, "What the heck happened? You guys were doing so well. You were on an uptick. What happened?" And it turned out that they had installed and implemented A1C testing at the point of care, but they hadn't link coded their A1C testing, and so they actually weren't getting credit for any of the testing that they were in fact doing. And you can see for blood pressure control and hypertension, for instance, this practice was at 70% blood pressure control as compared to the average at the time, which was 58% for these practices. So we've been giving them that data. We also give them some interesting other data, like the syndromic surveillance. They don't find that very interesting, but we do. And then we also give them a sense of how they're billing. We give them their CPT codes for all new and established patient visits. It's a way for us to engage with them on best practices in billing and coding, because a lot of the doctors we found don't understand coding at all. So this was our initial attempt at giving them back at least some of the measures that they were giving to us. We tried to highlight in green the measures that ended up being consonant with meaningful use measures, so we could, while we were handing out these dashboards, we could talk to them about the impact on and the overlap between these and their meaningful use measures on things like, for instance, e-prescribing, which the practices were historically not doing very well at. So we found that the providers really like this. When we send these out electronically, also the quality improvement specialists bring them to the practice and remind them that they're getting these in their email. And some of the feedback that we've gotten from practices are, for instance, when we saw the current medication reviews in red, I went to the doctor to make sure that we were reviewing all meds. So the practice administrator here got this and went to the doctor to explain to them how to that they needed to really focus on current meds reviewed, which, as many of you know, is one of the meaningful use measures. Another comment that we got back was, I see that Dr. Y isn't doing e-prescribing. If you look at what you need to improve on, you'll be more cognizant when patients come in and improve on that. And that was actually the lead practice gave us that information on one of his doctors. And he went and spoke with his colleague, and it reinforced the need to be e-prescribing. And so that provider went from 24% e-prescribing in 2010 to several years later, unfortunately, to 57%. And we've also, we know this anecdotal information, which is what the practices have been telling us. And then we also have done a little bit more of a rigorous look at the dashboard. So if you look at the average performance in the dashboard, the average performance of the practices before they got the dashboards, we looked at the top quartile and the bottom quartile, and you can really see that they varied. Like A1C testing, the top quartile was 65%. Bottom quartile was 27%. So we have a fair amount of variability in terms of quality of care that's being provided, documented and provided. And when we started to give them their dashboards, we took a look. I believe this was 9 to 12 months after we started giving them their dashboards, and you can really see that the high performers, the top quartile and the bottom quartile improve, and importantly, the bottom quartile improves much faster than the top quartile. And so for us, this was an indication that we had really stumbled on something, that really practices who were getting information back and we could engage with them in a helpful dialogue around their quality improvement were really willing to increase their performance. Which I think we've always said, like doctors, we think for them and practices are really well-meaning and they're trying to do their best, but sometimes they feel like they don't have the tools. And so by bringing some attention to important areas of focus and working with them on helping to improve, we really can eke out pretty significant quality gains. So overall, like I said, we've been looking at this is just another depiction of the same data of looking at, we started sending out the dashboards in October 2010, which you can actually probably even just tell from looking at these graphs alone, for practices that were above the benchmark before they got the graph. Before they got the dashboards, they improved, but those in the orange, which were below the benchmark at the time of the first dashboard, you can really see the uptick graphically there. So in terms of what we're working on next, now we're trying to, this is obviously public health integrating into primary care in a way that hasn't really been done by a lot of health departments. And so we're constantly trying to explore the bounds of what we can do, what will practice, how much will it be too much before the practices say, this is the health department, you got to get out of our business. So we're trying to understand a lot about how we can really partner with the primary care setting without annoying them to pieces. We're also trying to understand how we can have access to additional data that we could then report back to the practices, because we firmly believe that if we give them the data and we give them recommendations, that they are willing to work on them. And so we're looking at Medicaid claims data to be able to look at things like preventable hospitalizations and other more comprehensive quality measures beyond what's in their EHRs alone. We're leveraging our diabetes A1C registry. In New York City, A1C is a reportable event to the health department, and so we're trying to think about how we can use that data to help providers, and also looking at how we can eventually use health information exchange data to give information back to providers. We want to keep a continued focus on cardiovascular diseases, and we're going to work more closely now with just blood pressure and cholesterol and see if we can really make a dent in those beyond what we've already done. We're also playing around in the mental health space and trying to understand, are there similar evidence-based prompts and guidelines and data that we could give back to the provider community there that would help them improve the quality of care they're providing and help them improve their care coordination. We're in lots of discussions with ACOs and payers to understand how what we're doing can help them, as long as they're willing to use it in a way that helps their providers. So we're working on that. And we're also overall just thinking about how to use this data in a scalable way to improve quality, and also starting to explore whether or not we want to look at how we can have an impact on cost, and thinking about things like reducing redundant testing, or just making sure that providers have all the information they need to make the right decision. For instance, not admit a patient that doesn't need to be admitted just because the provider didn't have access to the EKG that shows that the finding that was seen today in the ER is actually an old finding, not a new finding. And so we're trying to understand if there's ways that we can impact that. And then lastly, we're also trying to posit some thinking around what is the validity of quality measurement out of electronic medical records. And we published a paper last year that looks in JAMIA that really looks at the validity of quality measurement. And what we found is on things like body mass index and aspirin therapy and vaccinations, essentially what you get out of the EHR is really what's happening. But if you compare, for instance, mammography screening from, you pull that out of the EHR from a quality measure, and then you compare that to an e-chart review, what you find is there are many areas where doctors don't actually do a good job of documenting, or they don't get the information back. So mammography screening is a great example of that, where it looks like the screening rates are something like 15%. That's because we consider, in the quality measure, we say, of all the people who were eligible for a mammogram, how many of them had the test ordered, done, and resulted? And a lot of doctors tell us they don't actually get the mammography results, or when they get them by fax and they stick them in patient documents, and they don't actually structure the data in a way that makes it detectable by the quality measure. And so we've been doing a lot of work to try to understand how is it that people should digest these quality measures that come out of EHRs, and importantly, how do you feed the data back to providers so they can understand, for instance, where they're recording smoking status. Many of them, only 50% of the time did they record smoking status in a location that was detectable by the quality measure. So they have a 50% drop in their performance just from documentation problems alone. So we are looking at additional quality measures and trying to understand what it will take to get them to the point where what you get out of the quality measure is a true reflection of what's actually happening at the practice. So that, in a brief nutshell, is what we've learned so far from our project. And I'm going to turn it over now to our next presenter, but I'll be happy to take any questions that you have. Thank you.
Well, thank you very much, Amanda. As I presage for our audience, very detailed and satisfying, and a lot of great stuff happening there. There are a few questions that came in from the audience that I do want to ask you directly. Just a couple. So the first one was, do you have a control population for the areas that did not implement an EMR? And I'm assuming by areas that probably means practices, but although it might mean locations. So certainly for some of the incentives, right, you presented control populations, but for the EMR implementations, did you have control groups that you were able to compare against where they didn't have EMRs implemented?
Unfortunately, no. We didn't give out our EHRs in a randomized clinical trial methodology. So it was basically a first come, first served, coalition of the willing at the time. What we are trying to do is look at, but we do know obviously who has an electronic medical record that we gave them. So we can do comparisons in some of the data sets, like the salient Medicaid claims data sets, and we've been working with the state to do comparisons. Unfortunately, we can't tell if they have an EHR at all. So, for instance, if it's a practice that's not known to us, we know that we did not implement their electronic medical record, but we have no good way of knowing whether or not they actually have an electronic medical record at all. So we'd be comparing practices who are in our program versus aren't in our program, and not so much the more interesting question, which is for those practices that got an EHR versus those practices that didn't. So we are constantly looking at different feasible opportunities to do that, but have not yet come up with a good, robust mechanism for doing so. And if anybody has any ideas, please feel free to email me. We're really open to that.
Okay. And, it's funny. It's for, a couple of years now here at AHRQ, I've said, we really need to have somebody, I hope somebody will submit to us a 2x2 study, a 2x2 box where, one side of the box is, has health IT, the other side doesn't have health IT, and then the other axis of the box is, high quality care and low quality care. So, places, so you could compare and contrast between them and try to figure out why, why each one sets up the way it does. So I thought that might be the question. A few questions came in about the results on slide 46. So, Elizabeth, it looks like you have the ball. Could you go backwards one slide, just a second here? And anyhow, so okay, there we go. So a couple questions came in and said that can you share the citation for the study on EHRs and quality measures from slide 46? It looked like a few folks had asked that. So I think you mentioned JAMIA. Do you have anything more specific?
Yeah, let me pull. Actually, what I'll do is let me type that into the. I'll go in and find the specific citation, and I'll type that into the text box.
Okay, perfect. I want to ask you two more quick questions. I appreciate you doing that offline because we do want to get to Elizabeth here in a second. Vanita asked, I noticed on the slide for providers who are incentivized that the groups labeled MCAID, which is probably Medicaid, or she says I assume Medicaid, that their results were in some instances less than the control group, and she was wondering why. I just didn't know if you had any insight that you might offer to that.
Let me turn to that slide. So the question is whether what the increase is less? Was that the question?
It says their results were in some instances less. So the control group.
Oh, yeah.
Sorry.
It's a great question. And so I think a lot of data has been, a lot of research has been done to show that patients who either are Medicaid or underinsured are from a lower socioeconomic income, and those who have more comorbidities are harder to treat, and so that's why you see them starting off at a baseline that's lower than patients who are not Medicaid patients or who don't have other comorbid diseases. And they've been shown so not only to have a higher burden of disease, which explains the baseline, but then also that they are harder to treat. For everything from their more barriers to them actually being able to access care and to actually fill their prescriptions and to have higher rates of medication adherence, et cetera. So I think that explains also for us the lower improvement in performance. They're just harder to treat patients. And essentially what you're looking at there is that's health disparities, measured health.
Made manifest, right?
made manifest.
Risk adjustment is the phrase that comes to mind, but I think that's well, that's really important though for folks who are just kind of digging into this stuff. And they look and they're going to sometimes they'll see things that are kind of counterintuitive.
Yeah.
So there was one more question that I'm going to actually take a quick stab at myself. It came up for your talk, but I'm guessing it might be applicable to the others. So the question from Diane was, so is the definition of quality improvement in these studies actual improvement in patient outcomes, or that the measure was appropriately documented? And I think, based on what you said and what the others are going to talk about, I'm pretty sure that, when you talk about quality improvement, you're actually talking about improving quality. You're talking about the right thing happening more often, or, et cetera. I think what you find when you start measuring these things is that you've got to measure it based on something, and unless you're going to sit there and have somebody check off a box every time the right thing happens, you've got to go to the records, and sometimes what you're looking for is not there in the records. So quality, even though when you get them to document better, quote unquote, the quality improves, it's not actually the quality improving. It's just that you're doing a more accurate measurement of it. Does that sound correct to you?
Yeah, I think, some of the measures are obviously more susceptible to documentation, like whether, documenting, mammogram, smoking cessation, but things like blood pressure, there's not really that many places in the electronic medical record that you can put a blood pressure. Usually it's in the blood pressure field, and there aren't usually multiple versions of that. And so the quality measure tends to be pretty accurate. And so for a blood pressure control measure, people have said, well, isn't that just documentation? No, actually, I didn't go into in details, but I did just send over to the citation. If you look at the paper, we showed that really blood pressure is really put in the right place like 99.9% of the time, and so what you're looking at is actually a true patient outcome, unless you believe that the documented blood pressure is not correct, in which case it would not be a reflection of the patient's health outcome.
Sure. Okay. So if you wouldn't mind, while you're listening to Dr. Alpern talk, if you wouldn't mind taking back a look through the questions that came in and see if there's some that you might want to answer. I would love to. This is a great talk. I do want to make sure that Elizabeth has enough time. So let me introduce to you Dr. Elizabeth Alpern, MD, MSCE. Dr. Alpern is an associate professor in the Department of Pediatrics and director of research in the Division of Emergency Medicine at the Children's Hospital of Philadelphia, the University of Pennsylvania, fondly known as CHOP. When I was up in Lancaster, it was the big house where you'd send the really sick kids. Dr. Alpern is both a pediatric emergency physician and clinical epidemiologist, and has particular interest and experience in the use of large databases within a research network and improving the quality of care delivered to children in the ED. She has been a member of the PECARN steering committee from the network's inception in 2001. She is the principal investigator for an AHRQ-funded project to develop the PECARN Emergency Care Registry, an electronic medical record registry with the goal to improve quality of care using data derived from this registry. Dr. Alpern is also the PI of the PECARN Core Data Project, PCDP, a database of over 6 million visits to all sites within the network for the past 12 years. Dr. Alpern, you already have a question kind of teed up for you. Lynn has asked, are there any pediatric-based studies? EHRs are notoriously not kid or prevention friendly, and many of these conditions have foundations in childhood. So I am looking forward to you trying to talk about that a little bit in your talk. So take it away, Dr. Alpern.
Thank you, Dr. White, and thank you for asking me to participate in this webinar. Lynn, I hope I'll answer somewhat of your question. I would like to acknowledge the support of AHRQ for this project and also the PECARN network infrastructure as it is supported through HRSA, MCHB, and EMSC. I would like to take a moment to point out the rationale and impetus behind our project. As noted in the IOM report, Emergency Care for Children Growing Pains, the emergency care provided to our children nationally is highly variable. At times it is really outstanding, and at other times significantly lacking. This variability presents an opportunity for improvement. In attempting to enact this improvement, it has become evident that basic administrative data is really severely limited in providing adequate reporting of performance measures needed to assess and improve the quality of care provided to our children. We identified the possibilities introduced by recent and ongoing advances, particularly the wealth of patient-centric data available in electronic health records used within emergency care settings, as well as technical advances such as natural language processing to help explore that wealth of data. We believe this combination may provide an opportunity to harness and strengthen the EHR data, measure the quality of care, and impact change. There were three overall aims of our project. The first is to develop an emergency care visit registry for pediatric patients. The registry is merged from electronic health record clinical data from different hospital emergency departments with differing electronic health record data sources. This new registry will serve as the foundation for current and future studies, obviating the need for resource-intensive chart review. The second aim will use this registry to collect stakeholder-prioritized emergency care performance measures for important pediatric medical and trauma conditions at the level of both the emergency department and the individual clinician. Using performance measure data, we will develop achievable benchmarks of care to promote performance improvement. The third aim will use this registry to report performance to individual emergency department clinicians and sites. We will test the hypothesis that providing regular performance measure feedback will improve performance and decrease variation among emergency department clinicians and sites. I will now give a brief overview of the entire project, and then we'll focus on particular successes and barriers that we have encountered to date. As you can see in this schematic of an overview of our project, starting on the upper left-hand side, we are taking electronic health record data from each and every patient emergency department visit from 4 sites within the PECARN network. Each of these sites has a main and a satellite emergency department, which will contribute data for a total of 8 study sites. The visit data is transmitted monthly to the Data Coordinating Center of PECARN, which is at the University of Utah, and I will review the transmission and de-identification process of the data in detail in a few moments. This data then forms the PECARN registry. Performance measures are derived from the data within the registry using both natural language processing, or NLP, and directly from distinct data variables. These derived performance measures will provide the information to build automated site and clinician-specific report cards. And our hope is that in providing regular performance measure feedback, we can improve performance, decrease variation among ED clinicians and sites using a time series study. We are currently approximately 2/5 of the way to completion of our project, so I will go over what we've already completed and also our future plans. The sites involved in the study are listed here, and as you can see, we are involving 4 geographically distinct sites with 3 different EHR vendors. We do, however, have some overlap between the vendors, and I will speak more to the pros and cons of particular aspects of this in a few moments. I was asked to review successes and barriers within our project to date, and I think that it's important to point out the components of the process that enabled our successes even prior to the start of the registry project. The PECARN network has a very strong and successful infrastructure that has benefited this project greatly. In particular, the network has been running the PECARN Core Data Project, as Dr. White mentioned, or the PCDP, for the last 10 years. The PCDP is an extant administrative database derived from all sites within the network, including all ED visits to those sites collected on an annual basis. This process has been successfully led by the investigators involved in the registry project and has allowed for prior collaborative projects between these investigators, the sites, and the data center. And it has given us the scaffolding to start our extensive work with the EHR that has led to the registry project. Another previous project of the PECARN network and the investigators of the registry project was to develop stakeholder-endorsed quality performance measures that comprehensively reflected pediatric emergency care. A selection of these performance measures are utilized in the PECARN registry project. The website provided on this slide has all 60 measures available and defined for open use. Members of the PECARN registry have also utilized natural language processing in prior research. NLP and free text parsing allow data from the discrete data elements and the narrative component of the EHR to be more fully utilized. However, medical narratives have both helpful components, such as the recurring use of stereotypical phrases such as alert and oriented, that can be exploited by natural language processing. There are, though, also difficulties introduced by typical medical writing, such as the unpredictable use of negation terms and punctuation. For example, no vomiting, fever is very different from no vomiting, fever. Prior to our project commencing, we did an NLP pilot as a test of concept using one of the projected performance measures. To evaluate the presence of seizure activity on arrival to the emergency department, which will ultimately be used to determine the quality measure timeliness of treatment with anti-epileptic drugs for patients in status epilepticus, we extracted a sample of records enriched in cases with seizure-related diagnoses. A natural language processing algorithm to classify the presence or absence of seizure activity on arrival to the emergency department was compared to administrative data determination, which used only triage acuity level and discharge diagnosis. The gold standard was manual chart review performed by 2 investigators. As you can see here, the NLP was better in identifying patients who were in status epilepticus on arrival to the emergency department. We were encouraged by these results, which suggested that even modest natural language processing efforts can markedly improve the precision and usefulness of the EHR data. In addition to the prior 2 preliminary processes, once we started the PECARN registry project, we were able to further enhance our productivity by relying on previous work. As I will illustrate in a few moments, the PECARN registry data variables are quite inclusive and contain all the limited previous PCDP variables. This allowed us a natural experiment of sorts to assess the proposed expanded data transfer process of the registry with the previously validated PCDP elements. We compared the 2012 PCDP data to select PECARN registry variables extracted and transmitted to the Data Coordinating Center utilizing the new XML transfer and XSD verification schema. From this, we learned to allow the same vendor sites to share the programming burden and used an open source tool to extract, transmit, and load the data. This also clued us into the added burden for the sole vendor sites within the project. We are currently building the registry with the 2012 data delivered from each site and planning ongoing monthly submissions. The process that we have developed for the registry build is to extract 1 day of data from each site, which is transmitted without de-identification to the Data Coordinating Center. This has allowed for a robust and site-specific de-identification procedure to be derived in a joint venture between the Data Coordinating Center, investigators with de-identification expertise at the Center for Biomedical Informatics at the Children's Hospital of Philadelphia, and technical support from investigators at each individual site. We then extract and de-identify 1 month of calendar year 2012 at the site to allow for quality assessment of both the variability of the variables and also as a de-identification process. We are currently completing this quality assessment and will then move on forward for transfer of the entire de-identified calendar year 2012. To allow for the data extraction, the registry investigators developed an explicit data dictionary for the definition of all variables, as well as the location and identification of those variables within each site's EHR. As you can see from the next slides, the PECARN registry variables are quite extensive. They include full demographic and patient-centric ED visit information, each with a date and time stamp, such as vital signs, orders, and therapeutics, including medications, clinical assessments, narratives, radiology and lab orders and results, procedures, diagnoses, and disposition. The performance measures which will be populated with data directly from the registry are listed here. They include both general and cross-cutting measures. Those on this slide are more within the site purview, such as time to diagnostic image availability. And as you can see from the next slide, there are several that are more within the locus of control of the provider. NLP, in concert with discrete variables, will be used to derive the measures as indicated here. I would like now to describe several of the successes and barriers in detail that we encountered to date. Due to the extensive nature of the data needed for the registry and the combined human subjects concerns of both patients and clinicians involved in the study, We have been very excited by our consistent successes in gaining IRB approval at all sites. This process was certainly helped by early and ongoing discussion of the project with IRB chairs and HIPAA officers at each site. We developed and rigorously held fast to a comprehensive single multi-center IRB protocol, which was reviewed prior to submission by select IRB chairs. In addition, this process was facilitated by existing relationships, including standing business association agreements between the sites and the data coordinating center. The barriers we encountered included the sheer amount of PHI involved and the desire to keep the risk of disclosure to a minimum. This meant significant time-consuming quality assessments of the de-identification process. We learned that there is an ongoing interplay between flexibility and security, and that amendments may be necessary to keep up with the required technical changes in the process. We also noted that within the full EHR, including all narratives, reports, and results, PHI can live in some very odd places, such as the lab result documentation indicating a callback to a particular clinician. As I have pointed out previously, this project is depending on evolving technology and those investigators that understand these methodologies. I truly believe our successes in this component are due to leveraging a strong, previously existing collaborative group of individuals within a dedicated and supported national network. This allowed us to ramp up quickly, build upon prior PECARN work together, including harnessing expertise and past successes in database design, development, data transmission, and EHR utilization. We were able across the sites that shared an EHR vendor to work as a single team with shared experiences and expertise to allow for data extraction and submission together. However, even within those sites utilizing a shared EHR, we learned that the rule is the exception and that each EHR is customized to the workflow of that individual site, and perhaps even worse, is subject to change at any moment, truly proving the point that the only thing constant is change. The sites without an EHR buddy within our project had a concentrated workload, and even more difficulty was encountered at the satellite site without active academic technology support, as the workflow of this site is significantly different from others in both availability of personnel and institutional support. Our extensive data transmission was enabled by utilizing a scale-up process that started with a single day of data. This small bite was perfect for allowing quick workflow that was responsive to changes needed, indicated by the rigorous quality improvement assessments. We developed extensive automated data quality reports that are produced each time data is submitted and then resubmitted that allows for quick review by all investigators. Modifications needed were identified by the reports, and the limited day of data allowed for facile changes in the extraction script. This iterative process was planned for within the grant timeline and fully utilized. However, as there are two sides to each coin, this iterative process was highly successful but also costly in terms of personnel and computing time and energies. We are also cognizant that EHR changes occur at all times and that a quote-unquote perfect single day of data may not generalize to a perfect month or year of data. So we need to be sure to continue to move forward within the iterative process, as it is possible to fall into the perfection time hole sink. Here is an example of one of our quality reports. As you can see here, to map even the more simple term of discharge disposition from the emergency department, we had to map variable expressions within and between sites. And that even within one site's EHR, the term discharged isn't so simple. If a patient is discharged directly from the ED, their disposition is discharged. However, as you can see here, if they are admitted to a 23-hour observation unit and ultimately discharged from the observation unit, their EHR disposition is also discharged. We needed to determine how to properly identify the subgroup's ED disposition as observation. As I pointed out, de-identification of significant amounts of PHI is necessary in the construction of the registry. Our process for this has been enhanced by exploiting both centralized and decentralized at the site expertise, utilizing a computer program to allow for extensive de-identification. This process leveraged our past experiences and knowledge of each site's EHR and resulted in our ability to deal with all PHI and date shifts for de-identification. We have noted, though, the tension between rigorous de-identification needed and the possibility of over-de-identification making narrative uninterpretable. For example, to use a ready example of Dr. White's name, if the de-identification program identifies the name White, as in Dr. White, there is the chance that white matter in the brain will also be de-identified if the program is not appropriately modified. In order to balance this tension, we have instituted a de-identification quality assessment that is both labor-intensive and will need periodic checks due to possible EHR changes.
Thank you, Dr. Alpern, just the way we planned it.
At this point, out there, we'll be heading into the remaining component of our project, and I'm sure we'll find new successes and barriers as we move along. I'll quickly just go through this component as I see we're running a little short on time. What we are planning to do is from the calendar 2012 data, we'll be deriving achievable benchmarks of care for each of the performance measures, and we will hold an expert panel discussion to identify ideal benchmarks as they may differ from the mathematically calculated benchmarks. We'll be producing automated clinician and site-specific report cards, and the clinician reports will be anonymous to all but that particular clinician. We have used input and experience from one of our investigators from another AHRQ-funded grant to help design our report cards. We'll have monthly ongoing transmission with distribution of report cards and assess the effects of providing this feedback on a site and clinician level. Our overall goals harken back to the rationale of conducting the project to evaluate our care of children in the emergency department, decrease variability, and also improve the quality of care they receive. However, the registry we are building to conduct this project has a wealth of data and will be a powerful tool in the future for EHR-based comparative effectiveness work. As I've previously said, most, if not all, of our successes are due to an amazing team of researchers within the sites and the data center, and I truly want to thank each of them for their contributions. Thank you for the opportunity to speak.
Superb. Well, I promised you three really, tight presentations packed with information, and that is exactly what you got. That was pretty amazing. So listen, a lot of really, Elizabeth, I don't have any specific questions for you, I think, at this point. Here's what I'm going to say. It's 2:55. We've just got a few minutes left. There are a lot of really good questions that have come through on the transom. We're not going to have time for all of them. So here's what I'd like to do. I'd like to ask one of them that's kind of relevant to all the rest of you. And here, I'd encourage the participants who've been listening the presenters have been really gracious in sharing their emails with you on these slides, that if your question does not get asked, take the opportunity to reach out to these folks who, I mean, really, they're on the cutting edge of doing this. They've been working hard at this for several years. So you should take the opportunity to tell them thank you for their presentations as well as ask them questions. If you want to answer that question and it doesn't get asked, please reach out to them and ask them the question, and they have graciously agreed to be available for you. So the one question that I do want to ask you all, it relates. You've described a lot of great work, and as Elizabeth's slide just showed, I mean, it takes a village. There's a lot of folks that are involved with doing this. So the question that came to us from Cynthia is: have you thought about teaching quality improvement specialists at each site, for instance, super users who can be on-site employees? Lynn offered a quick response that said it would be great for practices to appoint QI super users, but I wanted to give you all a chance to describe in a little more detail any efforts that you may have made along those lines, or other efforts like the extension program run by the Office of the National Coordinator that you may have experience with. Any of you that wants to answer would be wonderful.
Well, I'll just take a stab at it. This is Lynn Nemeth, and we have not gone through any of those other funding mechanisms to appoint super users at each practice, but we find that there's a natural kind of selection process that starts to happen in some of the practices we've worked in, where practice-based liaisons start to rise to the top and start assuming that role of being a super user who teaches others. it would be great to have that as a designated part, but that's a costly piece of a practice status, so not all practices can afford to do that.
Amanda or Elizabeth, any experience with this?
I was going to say, for the small practices, it's been really hard to identify who that person would be, because in general what we find is it's one or two doctors and then a very more entry-level receptionist person, and the doctors often don't have the time to be the clinic quality improvement specialist. So I'm not sure we have a good solution for embedding this at the small practices. Certainly at the community health centers, we work very closely with their teams. They often have one or more QI folks, and so we do work with them. We do collaboratives with them. We engage them on the data, so they're very much a part of our sort of train-the-trainer model. We're not formally responsible for training these people in QI, but we do train them on the methodologies that we use to improve the quality of care, and so that is in addition to whatever training that they get. I think it is a big opportunity nationwide to think about how to really scale up the workforce that's needed to use health IT as a methodology for improving the quality of care, but so far that's really been done, I would say, rather sort of haphazardly on our side, and really working with the coalition of the people who are willing to work with us.
And just briefly, I'll say that we were very lucky that we were working with QI experts already within the project, but did reach out to each site, and especially the satellite sites, administration and QI experts, as they are most interested in this data and can foresee that despite the significant work that it involves, the payback that they'll get exceeds that, and so we're very supportive of the project. So I do think tapping into what's already there has helped us greatly. We haven't done a grassroots project in growing.
Perfect. Good answers from all. On that note, we are at 3 o'clock, so I want to thank everybody for participating in this. 3 excellent presentations. Thank you to our presenters. For those of you who, like me, who like finding that rat pellet at the end of the maze, we do have CME and CNE credits are available. This last slide tells you that you can get up to 1.5 contact credit hours, and a link to the online evaluation system to get that will be sent to you within 48 hours after the event. So thank you very much, everybody. Thank you, doctors, for being online with us, and we hope you all will look forward to the next AHRQ Health IT teleconference coming up in the near future. So thank you, everybody.
Thank you.
Thank you.